To introduce to you our moderator, Jessica Jorgensen. She is the strategist for the healthcare division at NetApp, in which she's responsible for strategic healthcare vertical GTM programming and the cross-functional coordination of the business units that deliver value to the healthcare market. She also co-spears C-level executive programming and NetApp's Healthcare CXO Advisory Board Council. So join me in welcoming Jessica.
Thank you. Thank you, Jessica. Thank you, Health Tech Council, for inviting me here and for allowing me to have a presence here with this distinguished group. And it's a privilege and a pleasure to introduce our distinguished panels today. So we'll start with Robert Sheashley from UPMC.
Thanks. Thank you, Jessica. Hi, I'm Robert Sheashley. I am Director of Strategic Technology Optimization at University of Pittsburgh Medical Center. And just some brief background on my career. I've been in the information technology business for about 23 years. I was fortunate enough to begin my career at Electronic Data Systems, where the topic that we're having a conversation about this morning was something that was on everyone's radar and ingrained in our methodology, that being change management and the business about assimilating change into organizations, with systems being the foundation of that change. I've had a number of roles since EDS. I spent some time at Andersen Consulting, the organization that birthed Accenture, and during that time I was the transition manager of the Blue Cross Blue Shield Illinois and Texas merger, which I spent 3 years facilitating that merger with the folks here in Chicago at Healthcare Service Corporation, and I'll probably be speaking about some of those experiences because that was an enormous change management effort, along with obviously system consolidation, process harmonization. So I'm happy to be here, and I appreciate the opportunity to speak to you.
Hi, John Madison, Chief Medical Information Officer of Kaiser Permanente Southern California region. I had the privilege of leading the team that implemented our Health Connect effort in the largest and the first region, where we brought up every hospital, every clinic, every doc, every nurse over a period of less than 4 years. So change management was pretty central to everything we did to get about 65,000 users up and running in a fairly short period of time.
Hi, I'm Jim Howenstein. I'm the CIO at Inlow Medical Center in Chico, California. If you don't know where Chico is, it's 90 miles north of Sacramento and 90 miles south of Redding. I've been in information technology since 1965. I've got 46 years, almost 47 years in technology. I got into healthcare in 1983 at Long Beach Memorial and been at 6 other facilities across the United States, all the way to Miami, where I was at Miami Beach Medical Center. I've been an advocate for change throughout my career, and finally at Inlow Medical Center I've been able to do change management and what I call IT transformation, which I'll talk to you a little bit more about how we're structured and set up. I got some very strong beliefs in this, so I will turn it over to you, Tim.
Thanks. I'm Tim Birdsall. I'm the Chief Medical Information Officer for Cancer Treatment Centers of America. We're a network of 5 hospitals spread out across the country: Philadelphia, Atlanta, Chicago, Tulsa, Oklahoma, and Phoenix. And all we do is treat cancer patients. So we're unique in that we are able to focus on a very specific patient population. We went live with a fully integrated electronic health record system just a little over 5 years ago, after having what was a hodgepodge of electronic systems with legally a paper chart as our legal medical record. And we've been very effective at making the kinds of people changes that are necessary to make that effective. We have a long, long way to go, but we made a decision when we started planning for the EHR implementation that we were going to go big bang as opposed to incrementally rolling out modules. And while there are certainly some things I would change looking back in terms of how we approach that, at the same time, it did a huge amount of work to facilitate the transformation, really the change management around all of that, with a large group of physicians and nurses and other employees spread out across, literally across the entire country. So I'm happy to be here this morning.
Great, thank you, Tim. So today's panel, the biggest threat to transformation is the human factor. That could mean you, me, a combination of all of us. But as we know, information technology can solve almost any problem out there. We've shot men and women into space. We've cloned animals. We can track our kids via their GPS on their mobile devices. We can reroute our way to work based on traffic applications. And with the power of science and technology today, studies are showing that we can potentially even cure HIV in infants that are born with that virus. So that's pretty powerful. Technology is very, very powerful, but it doesn't stand alone. It's really a catalyst, right, for things that could be better. So today's panel, we're going to discuss the tenuous and delicate balance of what's needed between people, process, and technology. So before we get started, I'd just like to see a show of hands here. How many of you have either been a part of, or rolled out a project that was less than successful or delivered less ROI than what was intended? Okay, pretty much 100%. So this should be a good topic of conversation this morning. One more poll. How many of you have in your organizations today a PMO office? Okay, less than half, almost a third. So, Robert, we'll start with you. Why don't you talk a little bit about your organization, how you set up projects for success?
Sure, thanks. So we have a PMO. UPMC is it's four large divisions. We're a $10 billion company. We have hospital systems, physician services, commercial and international, and then we have our insurance services division. And we've been in the process over the past several years of consolidating a lot of the shared services, meaning information services being one of the larger ones, and human resources being another large shared services within the enterprise. We do have a PMO. It resides in the insurance services division, and there's a lot of discussion about raising that up to the enterprise. But our PMO is primarily focused on what Jessica just mentioned, and that is trying to strike a balance between technology delivery, process harmonization, and then the human factor, the assimilation of change as it relates to changing those processes and introducing new technology to the organization. Admittedly, I don't think we've reached the same level of maturity in all three of those areas. In my past lives, I've been a part of organizations, or in my consulting life have had clients that evolved to a balance of those maturity levels within either a PMO or a centralized shared services organization. I think for our purposes, change management is something that is evolving competency. In my past lives, one in particular project, 3-year, I mentioned it in the introduction, was the merger between Blue Cross Blue Shield of Illinois and Blue Cross Blue Shield of Texas. And as you can imagine, the cultural drag or differences associated with those two organizations it's tremendous. We're talking about Chicago and Dallas, and just culturally, the decision-making processes that the organizations would go through were very different. We were consolidating systems, and we were harmonizing processes across both enterprises to create one organization. And I think one of the greatest factors of our success, and it was a highly, highly successful integration producing an ROI 3 times that of the investment within a year and a half of the initial investment. One of the biggest factors was we actually took a very deliberate approach to change management, meaning we did readiness assessments with the executive team and middle management, and then kept a pulse on the measures associated with that readiness assessment, which was a series of interview questions, both anonymous as well as face-to-face. And although that seems kind of time-consuming, it really isn't when you start to measure the fact that failure was not an option for us in that particular program. We were being monitored, for lack of a better phrase, by the State Attorney General of Texas because of the nonprofit status and charitable status of the Texas plan. So failure wasn't an option for us. So that gave us further incentive to make a stronger investment in some of the change management techniques from the beginning, with the end in mind of having a successful consolidation that produced tangible value that we could point to and say we made savings in this area of XYZ, and we had cost avoidance of savings in this area of XYZ. Without the formal and informal champions within that 3-year program, I don't think we would have been nearly as successful. And a lot of the change techniques that we used, including DICE, which we can talk about as we continue the conversation, were valuable in that end.
Thank you. So John, what does success start with in your organization when you're looking at rolling out a project? How do you make sure that your team is successful in your project?
So there's a lot of things, and it really depends upon the project itself, but I think the universal factors are having a fairly well understood set of objectives, very clear executive support for that, communication and sponsorship, using the classical change management strategies of ensuring that everybody's on the same mission, they understand what the mission is. So I think your question is about the outset, and so all too often the scope and schedule of a project are not clearly understood by everyone, so that when you get into a competition for resources between that project and the other 5,000 things that everybody's being held accountable for today, you may lose in that competition for focus and priorities. So clearly articulating where it fits in the grander scheme and helping people prioritize along the way, I think is probably the most critical factor, aside from having good leadership. So change management and leadership to me are inextricably related, and so having folks who are really capable of motivating a team is absolutely essential.
Thank you. Now, Jim, you're doing some interesting things on your project teams with key constituents. Can you talk a little bit about how you're bringing your team together cross-functionally?
Yeah, understand Inlow Medical Center is a 298-bed, non-for-profit, community-based hospital, so I have a different look and take than maybe some of the other panelists here. I have to agree with everything that they're saying. But the challenges are a little bit different, and that is the best way to start out is 2.5 years ago, we got a new CEO, and the new CEO, shortly after he joined the organization, we had 2 failures. I see most of you had failures too. So he went out and got a consultant organization in for 9 months. After 9 months, he had to ask the consultant organization to leave because they did not live up to their contract. So he turned back to me and said, develop an organization, but don't at the same time, create a lot of non-essential structure. So what we did is we went out and formed what we call an advanced clinical group. An advanced clinical group came out of the nursing environment, didn't come out of IT. It has a combination of nursing, radiology, lab, pharmacy, emergency department, are all within this team. And they report up to a manager. That manager has a dual role, one to the CMIO who reports to me, and one half to the CNIO who reports to the VP of nursing. In that structure, the cost center resides out of administrative, nursing administration, not IT. We have one member who is a project manager. He's certified as a PMO, and he sits in there to make sure that all the IT processes are followed to the T. Change control, submitting requests. This group builds the systems. They implement the systems. They train and they support the end users, okay? It's not done by IT. So for us, when we look at moving forward, it's really a user-based ownership approach to our implementation. And that implementation, we have had no failures, and we've met every single timeline. We have Meditech. We did an optimization of Meditech system. We installed bedside medication verification. We installed EMR, and then we installed CPOE and physician documentation. All of those were done by the Advanced Clinical Group. In addition to the Advanced Clinical Group that's tied in there is 3 CIPSs, which are clinical informatics physician specialists. They came out of the hospital, and they range from an age of 38 up to 65. Physicians are the age range. They have done all of the physician build, implementation. They built a web page for training for physicians. This was all done by them, not IT. So when we look at change management and we look at transformation, the key is it has to be driven by the users. And our CEO cannot believe the type of response we have got from our committees or from the group and from the hospital. Nurses that want to leave nursing and join this group. Physicians that want to be a part of this team. One physician that was a CIPS has left and become my medical director of clinical analytics because it was so exciting. So it's a change in time for us. And what I can do, larger organizations have trouble doing because you've got to have a buy-in throughout the entire organization. And sometimes failures lead to success, and that's what we've had at INLO. So.
Nice, thank you. So Tim, you've been a CMIO now at the Cancer Treatment Centers of America for about 18 months, is that correct? What are some of the hurdles to success or the most common problems you've seen to date when trying to roll out a solution to the organization and affect transformation?
I think one of the challenges, and we've already talked about it, it's really even part of the core concept of this talk, is that solutions really do have to do with people and process and technology. And it's a classic three-legged stool, and a weak leg in any of those is going to create challenges, frankly challenges you may not be able to recover from. For us, the biggest component, I think, is communication from the very beginning on any kind of a project, a clear understanding of what the goals are, what are the parameters around the project, what's the classic in-scope, out-of-scope conversation to make sure that everybody's on the same page. And then frequent touch points as the project evolves. There are invariably going to be things that come up that are unexpected. There are going to be hurdles that have to be overcome, challenges that need to be worked through. At the end of the day, I'm absolutely convinced that people can subvert the best process and they can circumvent the best technology. And so the challenges are to make sure that you've got key people, key leaders who have bought into the process, who can be your advocates. John and I were talking last night at the reception about how important that is to have key leaders, particularly leaders in the physician and nursing communities who can advocate for change and for the process that you're attempting to put in place, so that it doesn't feel like it's coming from IT, it doesn't feel like it's a directive from on high, this is how you're going to do it now, but really people who understand both the clinical issues that those clinicians are going to face, as well as understanding the value of the technology solutions. At the end of the day, having a formalized project management structure is really important. We actually have, I hadn't even thought about this, we actually have 3 different PMOs in our organization. We do have an enterprise-wide Lean Six Sigma program that really functions in a variety of areas, including clinical, including IT, but certainly has a lot to do with other areas not directly related to clinical care or IT. And we do have a formal project management office, again, at an enterprise-wide level that takes on big projects. They, for example, are running our ICD-10 conversion project right now because it touches so many areas. And then about a year ago, we actually formed a dedicated project management office within IT to help manage those more IT-focused projects, system upgrades, and similar kinds of things. Those 3 groups actually work very, very well together and fairly seamlessly and draw on each other's skills, and in many cases we have collaborative efforts. The ICD-10 is a good example where we actually have all 3 groups involved to some extent in different components of a very large 18-month ICD-10 rollout.
Thank you. So Robert, you said the other day that most people are reticent to change, right? They don't like it, they don't do well with it or don't embrace it. So, and you also said that setting up a project for success begins with the end in mind. But how do you recognize when you're in the midst of a rollout or a transformation, how do you recognize gap to goal? What are some of the things or techniques that you're using?
Certainly. I think that the change management aspects of whether it's a large-scale change or it's a small project, building into, for lack of a more eloquent phrase, your work breakdown structure of your plan, some of the change activities for monitoring, and then treating that as you would any gap that you might encounter with your technology build, create an action plan on how to remediate what you believe to be the expectation at that point in time in the project. Tim mentioned something that I think I want to make sure that I incorporate it into my response because I think it's important, and that is having the and I think Jim mentioned it also. I think having the leadership, the formal and the informal influencers to be part of that ongoing monitoring process within your project or your program. There are always influencers, whether they be nurses or docs, that may not have leadership positions within the organization as it relates to a vertical solution delivery, but they are key influencers across the hospital system or across the service center that you want to make sure are plugged into what your expectations are at certain stage gate points of your program. So it's really incorporating the change management activities, depending upon what technique you choose to manage the change. It's not just about creating a training plan or a communication plan or a stakeholder needs analysis. It's actually monitoring those activities and then taking corrective action as you determine that we expected to be here with respect to the acceptance And when I speak in terms of acceptance, the psychology of change is always, originally denial. This change isn't happening to me. And at some point you get to the acceptance, and ultimately, hopefully you get to the point of ownership. But recognizing that you're not where you need to be within that change acceptance curve at any point in the program, and then taking action to remediate where you are intended to be versus where you may be.
Thank you. So John, you've been at Kaiser for a couple decades now or something like that. Yeah, longer than I've been alive. That's a joke. Or not. My Botox, I just got that done last week, so I'm looking better. Can you tell us what some of the unintended consequences are of change as it relates to organizational morale, physician RVUs, the delivery of patient care? What are some of the things that you've seen?
So the perennial priorities for our company are, quality of care, access and patient satisfaction, and then finally managing costs. And so when those priorities are what are being incentivized directly, disrupting everybody's life is not exactly welcomed because it impacts all three of those. And so what I was saying in response to the prior question about making sure that the priorities are very clear, it's really important so that people can incorporate that in amongst their priorities. So in terms of where there's real challenges, if you have a system deployment that is impacting people's ability to meet their access targets, they're not going to be very happy about it. And so one of the things that we learned is as the larger deployments roll through a facility, that they get some relief, temporary relief on those other targets so that they can actually meet the deployment targets without the adverse impact of the measuring of their primary targets in cost, quality, and access. So I think that if you're very clear about what your priorities are, and if you align the incentives of those priorities and you give relief to some of those incentives that may be impacted transiently during a deployment, you're much less likely to put people in the position of having to choose between recognition for their leadership skills and achievement of those targets, and yet succeed at the implementation at the same time. So the classic mistake is to say, just suck it up. And that's the surest way to get some resentment for the change that's underway.
Thank you. So let's take something that's applicable and on the forefront here, meaningful use. And as we prepare for meaningful use, keeping the end in mind, Jim, what are some of the things that you're doing in your organization to prepare yourself for that? And you can even go into Meaningful Use 3 if you so choose.
Okay, thanks, Jessica. First question, how many have attested for meaningful use and received their money? For stage one? Okay. Meaningful use, to me, is the first time that I felt IT could really make a difference to the organization. And the reason being is because it got the attention of the CEO. CEO says, come in one day and says, we've got to do meaningful use. I don't know what it means, but I know there's a carrot and a stick. The carrot is we're going to get some money. The stick is if we don't do it, guess what? We're going to get lower reimbursement. So as an organization, we put together a plan to move forward, and I took to the finance committee and the board a proposal for $8.5 million, knowing that we were going to get about $7 million back. They approved that program, and that was only for stage one. And at the time of going to the boards, the CEO, again, the committee or the chair of the boards, said, what if we don't do this? what if we just ignore it? And he said, well, we're still going to have to spend the money along the way. We won't get any money reimbursed. And by the way, in 2015, I think it is, our reimbursement's going to get cut. So it was pretty clear we could move, they signed off, we moved forward with it. The putting the plan together for meaningful use, stage 1, meant that we had to pull all of our partners in the organization, because a lot of their projects were not going to get done. We had some 60 projects on our plate. I have a staff of 42 people. With advanced clinicals, we're up to 60-some. But we weren't going to complete all the projects. So we had to get an agreement from all of our partners that this was a strategic initiative for the organization, and we needed to do it. The CEO took it to the group and said, your projects are on hold until we meet this. Lo and behold, what he didn't understand was that was stage 1, okay? Now we're into stage 2. Now I'm putting another budget together, which will lead to more capital expenditure, but guess what? We're not going to get any more money. The money was set in stage 1. There isn't any money that's going to be for stage 2 or stage 3. You just have to meet it and do the requirements for it. But what we did along with this is we took and really started digging down into our systems and finding out, when we report meaningful use, are all the indicators turned on in our systems? And I did that with a physician. A physician actually sat with my DBA person and went through every single numerator and denominator and made sure that the system was flagged in producing the data. I don't know how many organizations will take a physician and use them in that light, but it was very beneficial to us. We did a test for it. We did receive our money. We received our second payment from Medicaid, and in September we will be submitting for our second payment through CMS. We feel very fortunate that we have everybody buying into the process. Everybody believes it. Now that stage 1 and we're behind us, now we're planning stage 2, but at the same time, I've got all these other projects that were put on hold. So what we're doing is we're going back, and the executives are making the decision on what projects get done and what ones don't. And those projects that get fold into stage 2 meaningful use that we've got to do are projects that have an impact on the bottom line of the organization. If they do not affect patient care, if you, most of you are familiar with HCAHPS. HCAHPS means quality indicators. If your patients are not happy with you, guess what? In 2014, you're going to get less money. So quality is very important. So the systems we look at have to have a benefit from a quality standpoint, have to have a return on investment, and we have to fit that into doing stage 2 meaningful use. And as soon as we finish stage 2, which we will, then you go into stage 3, which we don't even know what stage 3 is right now. So it's a challenging time, but an exciting time to be in healthcare right now. And meaningful use, I am so happy it came through, because to me, it drove the vendors and the organizations to move forward with advanced clinicals, which they needed so much to deliver quality patient care. And vendors were reluctant in pushing for those systems. They weren't developing them fast enough, and hospitals didn't want to install them, and guess what? Physicians didn't want to use them. So now that physicians get an incentive, hospitals get an incentive, guess what? The outcome is better patient care for our patients.
Thank you. So you mentioned, Jim, and we'll go to Dr. Birdsall. If process is a key tenet, how do you and your organization, how do you effectively and clearly, capture that, articulate that into a workflow that ensures adoption? And does this differ when you're delivering a clinical or IT solution versus a change in the care delivery process?
One of the aha moments, I think, for me in the last 18 to 24 months has been how intimately tied configuration of electronic systems are to clinical process. As I said, we went live with our EHR 5 years ago and spent a lot of time doing process mapping and making sure that our configuration for our electronic systems matched the clinical process flow. And we had multiple hospitals to integrate into that, of course, in many cases, each one having their own clinical flow. So that's been an interesting challenge, and it's taken us a while, but I think organizationally we've come to grips with the fact that we all need to agree on single clinical processes. One of the areas that, in retrospect, that we failed in was that we didn't put controls around clinical process change linking back to IT change. So clinical process best practices continue to evolve, and there are changes every day with what is now considered to be best practice for X, Y, or Z. And we realized that in many cases, our clinical processes had gone through a very appropriate, effective change management decision tree around the clinical process, but without necessarily looking at what changes needed to be made on the IT side to accommodate that and to facilitate it. And even if the system accommodates something, it may become cumbersome if you don't have the right order sets built or those types of things. And so one of the takeaways for me has been to make sure that we continue to circle back around clinical process at a high level. We just completed a project about 60 days ago at all of our facilities looking at a high-level process map for every clinical process that touches an electronic system. So we actually have mapped now all of those clinical processes in typical flowchart kind of schemas, and all of that's, the flowcharts themselves are electronic and literally linked and available online. When people are looking at a process change now, they're actually looking at those process maps and identifying those touch points with IT. So that's like, when we change this process, that means that this order set needs to be changed here. We need to change the configuration of this document. That means that this report is now going to have to report on different fields. To try and link all of that back together to a single piece. Clinicians want to do the right thing by patients. They want to provide excellent patient care. We have to give them the tools to do that and to make it as easy as we can to do that. I also don't think that we should, deny the fact that moving from an old-fashioned paper record to electronic systems is going to inherently make clinicians more efficient. It doesn't. And unless you work really hard at it, the risk is that you make your clinician's job much more difficult, much more time-consuming, but you haven't decreased their patient load. And so, so the challenge is that we're going to be asking them to see the same number of patients or more patients, and, and at the same time, to do more work on the documentation side and the order entry side. So it's really our job to find those efficient tools that are going to make those jobs easier, and at the same time to provide better data, both for real-time prospective decision-making and retrospective data analysis.
Thank you. So John, I'm going to go back to you. Is it possible to successfully deliver a solution to the organization, but in the end not deliver for the patient?
So the answer is unequivocally yes. And it really depends upon how you align incentives and structure the project. So one of the things that we did to overcome, so every contingency in a healthcare organization needs to advocate for their own position and perspective. That's their obligation, that's their responsibility, and that's why they have a seat at the table. And because of that, it's pretty easy to get into a dispute between, say, a pharmacist and a physician, or a scheduler and a receptionist. And we did something very, very systematically. So we literally involved over 1,200 people in the configurations of our health record system when we rolled it out. And I'll use this as the best example, but we use the same approach for everything we do. And back to your earlier question about PMOs, we have 6 PMOs, and then we have what we call a cross-mega team that coordinates across all the PMOs, because we have multiple $50 to $100 million projects going at any point in time. Our health record project was a $3 billion project. And so it's really critical that you align what your goals are with the decision-making process. So what we did with those 1,200 people who actively participated in the configuration and the workflow configuration webinars were that we did not look at the individual feature or function of the application and say, how should we do this? We looked at the integrated end-to-end workflow and the actual process that was being addressed, rather than the set of features and functions of the systems. And whenever there was disagreement about how to extract most of the friction from the system and produce the most efficient approach to a particular workflow or problem, what I adamantly instructed every team to do in every one of these webinars, and we had literally hundreds of webinars involving people from all of our sites in the configuration process, was when there was a disagreement between, say, the pharmacist and the physician, or the receptionist, the scheduler, the neutralizing factor was always to say, what creates the best experience for the patient? And so that not only kept the entire process patient-centered and patient-focused, but it was ultimately the best way to motivate people to abandon their own proprietary and parochial concerns about their workflow and look at it from the patient perspective. So we would, in every instance, and we made tens of thousands of configuration decisions in the end-to-end workflows, and in every single case where there was any sort of contest between two different perspectives, we abandoned the parochial approach and went to how do we make it smoothest for the patient. And in so doing, you can achieve the most patient-centric approach and then circle back and say, okay, so how do we mitigate any adverse implications of these decisions that are patient-centric for the individual participants and stakeholders? And that was probably one of the top 3 or 4 success factors for our deployment. And I should say that we came in a year ahead of schedule and $260 million under budget. And I'm unaware of any other project of this size that has come in both well ahead of schedule and under budget. And I think putting the patient first not only benefited the patient, but it benefited the organization in terms of creating the most frictionless outcome for everybody.
Thank you. We have about 5 minutes left, so I'd like to open this up for questions from the audience if you have any. Does anyone have any questions? Yes.
Make that happen. Yeah, thank you. I'm Suresh Srinivasan, CTO from NY Langone Medical Center. This question is for Dr. Bursell. The process activity, was it led by the CMO function, or was it led by the IT function? I mean, you can talk through some of the tools that you used to make that happen.
The process mapping project actually started with the IT department, and just from a structural standpoint, as a CMIO, I have a dual solid line reporting relationship to the CIO and to the CMO. And the process mapping started really with an awareness of the problem I described by the IT department, but very quickly realized that we had to loop in clinical services to really make that effective. So it was a process of a dedicated individual. In this particular case, we did use a consultant with specific expertise in process flow and process mapping, who literally, we started with a map of applications and kind of a high-level view of who we thought was using which applications, and then started by just putting that person into each of those departments, into each of those job functions, and having them shadow people for maybe a half a day or a day, and just to track what the actual process is. It can be tracked in a variety of ways. We've actually ended up using Excel as a simple way to do that, and to link to various sheets between the process maps for individual departments, and posted that on our intranet site, so that all of our employees have access to that, both to kind of cross-check their current processes and to consider the implications of any changes.
Anyone else? Any other questions? Well, this was a very interesting discussion this morning, and there are a lot of takeaways I think that we can leave here as a group with. And here's what I've heard: foster collaboration cross-functionally, right? Regardless of role, nurses, clinicians, physicians, the patient, IT, finance, operations. Get clinicians involved early. The clinical needs to be the driver of change more than operational efficiencies or financial efficiencies, although very important. To really truly understand the needs and requirements early, so to do a lot of those assessments. We didn't have time to talk today about how do we measure success, but I had the privilege of speaking to the panelists before this morning, and they all have very unique ways in how they measure their success. So whether it's from an IT perspective, user adoption perspective, morale perspective. So as the day progresses on, please feel free to reach out to the panelists and ask them about how they measure success, because all very unique, very different, and different perspectives, especially from the CMIO perspective to the CIO perspective. So again, thank you for your time and attention, and I'll turn this back over to Jessica.
Thank you, Jessica, very much. Round of applause for them, please.